Good morning, everyone, and thank you so much for joining us at the Public Safety Solutions for Substance Use Disorder ECHO, brought to you by Center for Substance Use Training and Telementoring, CSTAT, at Beeville, Texas. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick housekeeping notes before we begin. These sessions are enabled for live closed captioning. If you would like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. To help us with attendance, please enter your name, affiliation, and email into the chat. To access the chat feature, click on the speech bubble icon on the navigation bar at the bottom of your window. Also, please note that we are recording these sessions for later distribution through the Beeville, Texas YouTube channel. Any information you put into the chat will not be shared in these recordings. We encourage everyone to join by video, especially for the discussion portion in the latter half of the session. That said, regardless of how you're here today, we are just happy you're here to learn alongside us. Please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, your mute button is at the bottom left of your Zoom controls. If you are on the phone, just press *6 to mute and unmute. You can also use the reactions menu in the bottom right of your Zoom controls to raise your hand and indicate that you have a comment to share. You can also use the chat to share your comments, questions, and perspectives. There are a lot of us in this space, so please do keep your comments brief to allow others an opportunity to speak up. And finally, please note that no protected health information is allowed in either the chat or the discussions, and that includes names, emails, addresses, or anything that can easily identify an individual. Towards the end of the session, the Beeville, Texas team will send out a link to a post-session survey. Please fill it out for a few reasons. It gives us your feedback on how to refine and shape these sessions to address your priorities, and it also allows you to access free continuing education credits. We are approved for CEs for paramedics and any public safety professionals with a behavioral health degree. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Today's session will start with a presentation from Cynthia Mendiola on building bridges supporting formerly incarcerated individuals with SUD and mental health challenges. Following that, we will hear a case from the community. There are a lot of professions represented here today, a lot of experiences and perspectives. I encourage you all to share your questions, insights, and thoughts in our discussion today so that we can learn from each other in the space. And with that, we will do some introductions. Cynthia. Can you please unmute yourself?
Thank you. I'm a little tech challenged, but my name is Cynthia Mendiola. I am a retired federal probation officer, and I have a specialty in substance use disorders. And I also am a trainer and coach, and I'm happy to be here today.
Thank you so much for joining us today. Brandon?
Yeah, hi, my name is Brandon Del Pozo. I'm a professor of medicine and public health at Brown University. I was a police officer for 23 years, 19 in the New York City Police Department, 4 as the chief of police of Burlington, Vermont. Love every chance I get to connect with folks in Texas, and I'm very happy to be here.
Thank you so much for joining us today. Dr. Miramontes.
Hi, good morning. Good morning. I'm Dr. Dave Miramontes. I'm the medical director for the San Antonio Fire Department, and we have a very active buprenorphine and outreach program within the fire department with our paramedics and EMTs.
Thank you so much for joining us. Jeremiah.
Hi, everybody. I'm Jeremiah Gulka, Executive Director of the SHIELD Training Initiative. We do occupational health and safety trainings for first responders, police, criminal justice personnel in their response to the overdose crisis. Looking forward to the conversation today.
Thank you so much. Cynthia Gonzalez.
My name is Cynthia Gonzalez. Can you hear me?
Yes.
Yes. My name is Cynthia Gonzalez. I am a senior U.S. probation officer here in San Antonio, and I enjoy listening in on these trainings, and I now get to partake in this one. So thank you for having me.
Thank you so much for joining us today. Andrea Hebler.
Hello, everyone. My name is Andrea Helbler, and I'm one of the program coordinators here at the Center for Substance Use Training and Telementoring CSTEP. Welcome, everybody.
Thank you. And with that, we will move on to our didactics. Karen, if you could please share the didactics, and Cynthia, you can take it away whenever you're ready.
Thank you. I'm not sure if I need to read the disclosures, but I can. All speakers and all members of the planning committee have no relevant financial relationship with a commercial interest or to disclose. The views and the opinions expressed by the participants and speakers attending the ECHO sessions are solely the opinions, and they do not reflect the official position of the policy with UT Health San Antonio. With that, let's move into the learning objectives for this session today. What we're going to be looking at is identifying ways to help formerly incarcerated individuals with substance use and mental health disorders transition into the community. We're also going to review some statistical facts about individuals coming out of confined facilities. We'll also discuss prison treatment services and some national initiatives that are coming out or that have been out for a while, and the information is out there if you like to locate them. And then explain reentry activities and ways to contribute to the continuum of care for these individuals. So what are the facts? We have 448,432 individuals that were released from the federal prisons. Out of those, we have also 600,000, and it's going up. I read another report that said it was 650,000 each year from the correctional facilities, and these are the state facilities. And I needed to clarify that. So we're looking at over 1 million to 1,200,000 people coming out of the prisons and correctional facilities. What I found from the federal institutions is 314 or 315,000 of those were on conditional release. And when we talk about conditional release, we mean that these people are coming out to a supervision term, and they are coming out with some conditions to be on supervision. But this is the one that really worries me for these individuals, is that 116,000 result in unconditional release, meaning a lot of these individuals, the 116,000, come out with no transition services, with no help and no conditions, so no supervision. So the other thing that I have found is the average annual cost of these individuals, for example, that are incarcerated in the Bureau of Prisons, is over 29,000 per individual, per inmate. And then there's also a disparity with the federal, you can put it into the next slide. Oh, you have it on the next slide. So I'm sorry. So we have these individuals that are coming out with the cost of prison much more than if they were to come out to us. They were in a sober living home or in a residential reentry. They're all called halfway houses. And the cost of that is $27,000 per each person. Now, the community supervision is between $3,000 and $3,300 for an individual being on supervision. That's the cost, okay? So what I'm trying to point out is that it behooves us to work with these individuals in the community supervision level and save money for one, but to also help them transition into the community well. 45% of prison admissions are the result of probation and parole violations. So this is really interesting, with the annual cost of $2.8 billion for just the technical violations. When I talk about technical violations, I'm talking about missing an appointment, not calling in when you were supposed to, having a positive urine specimen, which may be an indicator of someone having a substance use disorder that's probably not untreated. Or, it could be somebody who, ends up with individuals that are using and end up using with those individuals, maybe not with a substance use disorder. So 9 million cycled through the jails. And that's another number. The jails is the short-term time that they get in if they are rearrested. But most of these technical violations are a large majority of people that are going back to prison. Next slide. So what's the goal? You know, and I'm talking mostly for community supervision officers, but mostly for everyone that touches the lives of these individuals. It's a seamless transition into the community and a robust continuum of care for these individuals that have been incarcerated and come out with substance use and mental health disorders. The other goal is for officers to use core correctional interventions to address the criminogenic risk factors. And these are the ones that determine the recidivism and also to be able to reduce the risk of reincarceration. Some of the main risk factors that really need to be addressed when you're working with these individuals is number one risk factor for going back to prison is associating with antisocial peers. The second one is antisocial attitudes, values, and beliefs. So these are the two major, well, there's three, but the two major ones that really need to be addressed. However, what I always say is that you can't work on these things when individuals who have substance use disorders and mental health come out with being unstable, not on their medications like they need to be, because you have mental health individuals trying to, who are not on their medication, trying to self-medicate some of their symptoms. And then you have substance use individuals with substance use disorders who are also self-medicating and are not on the medications that they need to be in order to be stable. And so before we can do any kind of work, any kind of treatment, when I say treatment, sitting in groups or having individual sessions, we really need to have them set up and stable with their medications. Next. So let's look at some of the barriers that we are often seeing or some of these individuals are challenged with. And the main one is prescribed medication while incarcerated. And when I talk about it while incarcerated, these individuals in the federal system, and it's really difficult to see in the states because everything differs from state to state. But I know for a fact in the federal system, when these individuals go into treatment in the federal prison, they are allowed to come out and transition in a halfway house and then into the community. And during that time, they are able to get medication. If they need medications, if we need medications for opioid use disorders, these individuals will be able to get that. The problem with that is that as they come out of the halfway house or the reentry center, they only have a week's worth of medication. And we all know that this is a continued need, not past a week. People aren't cured. You need that medication that needs to go on as an adjunct to their treatment services. Many of these individuals either didn't receive or failed to report prior treatment for mental time of release, we don't know about that. So, excuse me. Other research reports, and I'll let you know that the third bullet was a research report indicating that there are some emotional barriers of survival in prison and the jails, in the jail culture. So, individuals that are wanting to seek behavioral health care, that's a barrier for them because it shows that they're weak or vulnerable, and in the prison and jail culture, that's something that can't be seen. So that's a barrier for some of these individuals that really want to have some treatment and are unable to because of that emotional barrier. The other barrier that we see, and I've seen this for many, many, many years, is that within the first 90 days of release, you have a great deal of a high risk for overdose. And I think we were talking in another session about how the fentanyl influences that as well, because you have individuals going into prison who may have been using other substances and come out thinking that they can still use the same substances at the same quantities and are really not aware of how the fentanyl influences those other drugs that they were using. So many of these individuals tend to come out and use the way they used to, creating a high risk for overdose. And then also not to exclude the fact that they come out, when they come out into the community, you have rearrests for minor crimes, many of them that are rooted in basic human needs, if they're not transitioned and transitioned well and stable into the community. The other barrier that I've seen, and I've interviewed some officers and kind of touched base, and again, I've interviewed mostly a lot of the federal officers, a few county probation officers, but mostly is that there is ineffective lines of communication between the community supervision officers, the treatment providers, and case managers and prison staff. And so when I say that ineffective is that it's possible that some of these officers aren't aware, or they don't have the knowledge as to how far they can go to communicate with treatment providers when these individuals are in the transitional stage and the reentry part before they come out into the community. Also, they may not be aware that they can go in, call in, or even if the prisons are close by, go in and talk with and converse, or even um, communicate and staff those individuals that are going to be coming out that are specifically in treatment in the prisons, and get the information so that they can transition instead of reinventing the wheel and starting over. And the last one is I just mentioned is the lack of knowledge of, there could be a lack of knowledge for a lot of these individuals who may not be specially trained in the areas of substance use and mental health disorders, as well as other reentry activities that they're able to go into and follow up in order to transition these individuals. The main thing that I've noticed also is that there are evidence-based practices and best practices that come down from the administrative offices, for example, Washington or the federal level, that come down to different organizations, community service supervision organizations. But what's lacking is that the processes rooted in those evidence-based practices are being lost. Either they're lost, or they're not in place, or they have kind of been watered down due to the lack of knowledge and specialized training. Next one. So the areas of need in reentry, when I talk about reentry, is those individuals that are coming out of prison, some of which are ending up in sober living homes, some are in halfway houses, some on reentry centers. These individuals come out with needing services in substance use and treatment services, mental health services, and that also includes medication-assisted therapy. The medications that are an adjunct to their success in the treatment services. Other areas of reentry is the workforce. You know, some of these individuals have never interviewed, don't have the ability to, either don't know or have the ability to fill out applications or even navigate through the websites because they've been in prison, and when they went in, some may not have known how or even had the knowledge of working through internet or using the computers. Housing is also an area of need in reentry, in which many of these individuals who are convicted felons are unable to get into housing because there are rules in the housing development organizations that restrict individuals that have felony convictions or drug charges. Vocational training is another need in which individuals come out with a lack of training, or if they do have training that is offered in the prison, then it's difficult for them to get into that particular field based upon their background. We have a lot of individuals that come out of the prison systems who have a lot of medical issues, many of which may have have incurred tuberculosis and are being treated for that, who have hep C, and also are being treated for that and come out with those needs that have to be transitioned into those medical services. And that is also another barrier because they come out with, well, lack of money, lack of connections, not knowing where to go to get that medical services. The biggest one is transportation, because in order to get to your employment or to anywhere that you need to get, even to your appointments with your supervision officers, is transportation. And many of these individuals get their licenses suspended because they have a drug charge. And many of these individuals end up with the inability to get to and from wherever they need to get to in order to be successful in the community again. And lastly, one of the most important things in order to get a job, in order to get medical assistance, in order to get a driver's license, I mean, in order to drive, you need Social Security card, driver's license, and all of those identifying documents in order to even get started in the community, get in the workforce. So these are all areas of need and reentry, and also barriers for individuals when they come out not having the necessary documents and the necessary processes set up for them in order to transition into the community. Next one. Other overwhelming barriers, are some facts, is that a lot of these individuals that release are parents and owe an average of $20,000 to $36,000 in child support. So you have a debt that they are going to have to be responsible for at the time that they step out into the community. The one thing that we know is an unemployed justice-involved person is 3 to 5 times more likely to return to prison. And so what we see is that if there's no way to be able to support themselves, then we're looking at some of the things I talked earlier, is the barriers of basic human needs and committing crimes in order to deal with some of those needs that they have to in order to survive. Again, I talked about is a high risk of overdose, a high risk of suicide, and rearrest within the first 90 days of release. And this has been known since I have been working in the federal system as a federal probation officer, is that we always known that within the first 90 days, we really have to help these individuals to pick up the pieces of their lives that fell apart when they went into prison. And in those first 90 days, we need to be ready to help them transition successfully so that they can continue with their lives in the community. Again, driver's license are suspended due to having drug charges. And so you have a lot of individuals coming out with no driver's license. And actually, one of the committed crimes is that, they feel they don't have a choice and are driving without their licenses. So they pick up some traffic violations. And those are violations that I also consider are technical violations that could probably be avoided if we do certain things to help them. Next one. So who are the key players? The key players, and I call it key players, are the individuals that touch the lives of our formerly incarcerated individuals. We have behavioral health professionals in the prison systems who work with these individuals and are helping them with mental health and substance use disorder treatment services. We have transitional services I know in the federal prison, we have a program where individuals, the last 120 to 180 days or 4 to 6 months, they're allowed to transition into a reentry center, residential reentry center, also called a halfway house. And at that point, they are provided services, continued services for their treatment. So they're transitioned to the next stage of treatment and provided those services to include medication-assisted therapy. Or MOUD, medication for opioid use disorders as well, and also for mental health. So the continuation of the prescription medication is done during that time in the reentry centers. So the key players are those individuals that are working with them at that point. And so for officers, it's important to collaborate with these treatment providers. And it's also important for treatment providers to know that they can communicate with the probation officers before these individuals are even released from prison. So during this time at the reentry center, they're considered to be still an inmate or a prisoner of the federal system. And I'm wondering also, I mean, it takes a while for the states to also come together and do some of these things. But I'm sure there's some people in the audience who work more with the state than I do and could give us some information on that, whether there are individuals doing or in the transitional stages also in the state system from coming out from prison. So so community supervision officers can establish contact prior to release, and so they're key players. This is an important part, and I used to get pushback from individuals and some officers sometimes because the issue was attorneys and the courts can be a really important part in the transition of these individuals, because what we can do as probation officers and even as treatment providers to bring these points up to the probation officer is to be proactive and have modifications of condition to include treatment services if that's what's going to be needed. And it's found that they do have substance use or mental health disorder issues in the prison. They're going to get that treatment and they're going to get those services. But if there isn't a condition for it, probation officers can modify and include that condition before they come out so that services can continue. All other things that are important is many of these individuals have traffic violations before they go to prison. And some of these traffic violations may not be a big deal to us because we can easily go up and pay those traffic violations. But for these individuals that go into prison, those violations continue to accrue in penalties and fees that could probably be taken care of before that person comes out. You know, there are so many situations where I have written letters to the courts, the traffic or the municipal courts, explaining that these individuals served time in prison, they did so much time, and requesting if they would consider, respectfully of course, consider dismissal of those tickets and giving them credit for time in that they served in prison. And I have gotten many responses where the judges have done that. The key is, do you want to take that extra step and help these individuals to avoid being arrested for tickets and start all over again when they're out in the community and just came out? And so these are some proactive things that we can do. And all you need to do is talk to the attorneys and tell them, look, I'm here to help them. Would you authorize me or let me talk to them and sign a waiver so that we can modify conditions or ask the courts to give them credit for time served? And the attorneys will almost always say yes, because you're trying to help them. And the last key player are the community partners. And so when I say community partners, it takes time to establish those partners. And so probation officers can be key players in that, where they can bring together those individuals that touch or the providers and community agencies, faith-based agencies that touch the lives of these individuals and that can provide services with all of the different types of basic human needs that are needed. So all areas of basic needs in order to have services readily available to access upon individuals' needs is important. And it's important if we have these community partners in place so that we can access them and leverage those resources together. Next one, please. So some examples of some reentry activities that occur in the federal system is the residential drug program. It's called the RDAP of the Bureau of Prisons. It is a 500-hour residential drug program. It also has a transitional phase to residential reentry centers 4 to 6 months prior to release. They set up continued treatment services prior to that release and transition the individual to the next phase of their treatment services. They also, in this program, they also help with a medicated assisted therapy for substance use disorders and mental health, because they do know that many times these are co-occurring occurring disorders and need to be addressed together and not in silos. There is an electronic progress report that is sent to the probation officer and the treatment providers during the reentry stage, and they're able to see, what is the progress of this individual. The other thing that is important is they also have them as part of the residential reentry. They have access to holding mock job fairs and having them participate in that, develop their job ready folder. They have document retrieval and application assistance, so they're able to get their documents before they come out. They have their social security card, and the other, the driver's license may not, but it's possible that they can work on that. I'm not sure if they've passed that barrier. But the one thing that is important for everyone to know is the certificate that they get from this program or any other program that they do in the state facilities qualifies them to have the removal of the suspended driver's license. So if they can turn in that certificate to the Texas Department of Public Safety and justify that they were in a program that qualifies them to remove the suspended driver's license, and they're able to be ready for that, to be able to get to be able to drive. Sorry. Next one. And quickly, I'm not sure how much time I have, but I think I'm almost out of time, right? Really quickly, there also are drug treatment programs, substance use disorder treatment programs in the TDCJ. One is called SAFE, and that is for individuals that are on probation that get a condition for treatment, and the other one is for parole. And they're both the same program, but it's different conditions. The main thing I wanted to talk about is I already talked a little bit about how these individuals can work with the treatment providers, but there are so many different other things that I run out of time that we can do. We could probably do another session. But the main thing I wanted to talk about is there's national initiatives. And I just found this out. I went to a conference that the United States Department of Health and Human Services, with the help of the Substance Abuse Mental Health Services, SAMHSA, have worked on a MOUD policy, and they have finally revised after 20 years, Title 42 CFR Part 8, and they revised it to increase provisions for medications for opioid use disorders in the federal prisons. So they're going to be able to allow this in the federal prisons where individuals can already have that medication that they need. The other thing is that the prisons, it is a national initiative to help obtain documents for release. And then the last thing is the National Institute of Corrections is a training agency tied to the Bureau of Prisons, but they provide technical assistant grants and training for any community supervision, any organization, treatment providers, and community supervision organizations that work with individuals that have been formerly incarcerated or individuals under the criminal justice system. And so with that, I know we don't have much more time. There was a little bit more I wanted to talk about, but I think it's important that you get all of these information about the national initiatives and then some of my resources that I looked up for these statistics.
Thank you so much, Cynthia, for the wonderful presentation. We may have time for maybe just one question from the audience. All right, we will move on to the next part of our session. Thank you again, Cynthia, for this wonderful presentation and very, very timely and relevant information. Please keep your questions and comments coming in the chat, and Cynthia can address them as we go. In the meanwhile, Karen, if you could please bring up the announcements from CSTAT. The Center for Substance Use Training and Telementoring offers technical assistance for various substance use disorder needs and topics via our team of experts. To request technical assistance, please complete an online request form and we'll be pleased to help you. And we can drop this link in the chat as well. Next slide, please. Do you have a difficult case that you or your team have encountered? CSTAT offers you the opportunity to present any challenge your organization is encountering and receive expert feedback from our hub members. You don't need to prepare a formal presentation. We will provide you a case form to fill out to assist with your case presentation. Please email us at cstat@yudhiska.edu. Next slide. To claim your CE credit, you must complete the post-session survey using the link in the chat, or we will also be sending that by email as well. When you complete the post-session survey, please select yes on the question, are you applying for CEU credit for today's ECHO session? And we will be able to send you a certificate of completion within the next 2 to 3 weeks. If you have any questions, please email bwelltx@yudhiska.edu. Next slide. And please join us for our next Public Safety Solutions ECHO session on Thursday, October 10th. We have an interesting session lined up. And with that, we will move on to our case for today. Karen, if you could please bring up the case, and Cynthia, you can take it away whenever you're ready.
Okay. Hello, everyone. And just in case y'all did not know this, but Cynthia Mendiola and myself used to work together for many, many years. So I am excited to almost be where she's at, and that is retired. So this case, and I have monitors up, so if it looks like I'm not looking at y'all, I apologize. I'm looking at my screen. A lot of what Cynthia Mendiola discussed is our day-to-day job duties here at the Federal Probation Office. And we do a lot of BOP reentry is what we call it, the Bureau of Prisons. That's our federal prison, Bureau of Prisons. And our case managers who are at the halfway house, they are technically part of the Bureau of Prisons. So we do a lot of communication with them and staffing, because again, we want to ensure these services that she talked about are met. However, we've come to realize there was we weren't aware of everything that was going on. So in this case, a person under supervision who was still in custody was receiving, and forgive me for not saying this correctly, I was looking it up while you were talking, buprenorphine. Somebody please correct me on how to say Suboxone's technical name. Is that the right way to say it?
Yeah, that's basically right. You can say buprenorphine, or Suboxone is a tamper-resistant form of buprenorphine.
Okay, buprenorphine. Thank you.
Mhm.
So this person was given buprenorphine while he was still at the halfway house, while he was still in custody. The Federal Probation Officer, myself, we meet with him, we meet with the case manager, and somehow never became aware that this person was taking this medication or was even prescribed. Now, why such a lack of communication? We did not realize our Bureau of Prison was prescribing this. And the case manager just didn't notify us, plain and simple. So now comes time for that person who was in custody to be released. He is released from the Bureau of Prisons and now is under our custody, federal supervision. When he releases from the Bureau of Prisons, guess who was paying for it while he was at the Bureau of Prisons? The Bureau of Prison, even while he was at the halfway house. Again, he's still in custody, so they're paying for it. But when he steps foot outside of that halfway house, his sentence is done, so is the money, and so is the prescription. So our office, in this individual's case, our office became aware of it, wondering like, what prescription are you talking about that you were taking? We had no idea. That has since been remedied, but we had no standard operating procedure on literally how to handle these individuals who are releasing, who were on this medication. What do we do? Because again, we were kind of caught in the dark, had no clue that this medication was even being prescribed while they were in custody, much less prescribed in general. This individual was addicted to opiates, fentanyl, He had a long substance use history. He had been an inpatient, been an outpatient. As fast forward, we got him the help he needed. He was referred to a MAT program who prescribed him that medication. He's doing well. He had a little bit of bumps here and there. Right now, he's stable residence and stable employment. We remedied the issue with our case managers / Bureau of Prison staff because we had to meet with them to say, how come we weren't advised of this information? And it just was something that never really crossed their mind. And so we even met with the doctor who was prescribing this and referring out to certain MAT agencies. And that doctor did not realize, oh yeah, they continue supervision. The doctor kind of looked at it like, well, they're done with us. Next, who's next? Who do we need to prescribe to next? So it was a revolving door on their end. And for us, it was a learning experience. We were able to get this MAP program to actually come to our office and educate the officers because we want to be up on what's done on the outside, what's being prescribed, how it's being prescribed, how it's given. So it's been an education experience for us because we were caught again, we were in the dark and the communication lines were a little bit like this, but now we're a lot more in sync. One of the questions, what would I do differently if I had this scenario again? Well, if it happened at the same time, we wouldn't know that, again, that this individual was on any type of medication. We had no idea. This individual has been referred out to community resource. We call them Access here in San Antonio. They're a great resource that we use for mental health and medication monitoring type services. I know I said that really fast. Does anyone have any questions for me?
Thank you so much, Cynthia, for bringing this case to us and for sharing it with us today. So I'll open up the floor for any questions or comments from our community here today.
I have a question. Cindy, do you by any chance get that electronic progress report from the Bureau of Prisons that pretty much tells you everything and anything that person is doing in treatment? Or has that fallen by the wayside?
No, we do receive reports from the Bureau of Prisons, letting us know how that individual has done in prison, what classes they've completed. Maybe they did their GED, they did maybe a drug type class, maybe they did a vocational type class. So we do get those, yes. And one thing for those who might not understand the federal system is a lot of times when these individuals are sentenced or go to prison, maybe they were on supervision and got revoked and got sent back, as we call it. They don't always go to what you might think of as the big prison. They might go to a community Carnes detention facility or Eden Detention Center. They might go to these places that don't offer any of those type of services. Our prisons are overpopulated and so are our detention centers. So if they get sent to a detention center, they're kind of SOL and don't get offered these type of programs.
Hi, this is Diane Thomas. I too am retired federal probation. How are you? Hey, Cynthia, and hey, Cindy.
Hey.
One of the things, how are you? I currently work for the Bell County Juvenile Detention Facility. And one of the things that they have here, which is totally amazing, is a reentry team. What the reentry team does, they actually go out, they meet with the client while they're still in custody, find out where they're going to live. They go to the residence, they look for all employment in that particular area. That's walking distance. I mean, they find out all the information from the client in regards to employment, medication, community resources that are close by for them, which is a lot of work for the officer to do, but a great job for a reentry team. So when that client releases, they've already talked to the doctor. They already got it set up for continued appointment when they release. They already have their employment and job interview lined up for them when they release. So if creating a reentry team, if it is possible, it is so great to have a smooth transition from custody back into the community.
That's a great idea. I think you should submit that to our administration.
Yes.
Yeah, that's a great idea.
Thank you, Deanne.
So does Dr. Miramontes. So I just want to reiterate to the non-medical folks on this call that if you've been incarcerated and not on treatment and you get out, your tolerance level is 0. So that means if you go out and try and use what you used to use before you went in, you most certainly are going to die. The fentanyl that's available now is so potent and so quick acting. A lot of these folks, when we see them in the fire department, they still have a needle in their arm and they haven't even done pushing their entire load into their vein and they're already dead. So it's really important. This is not just administrative and bureaucracy. Oh, he needs a prescription. This is a life-saving, life-changing treatment that really has to be very high on the priority list for the probation officer and the entry team. And unfortunately, most of the time, these clients really slip through the cracks. A week is not a lot of time of medications to get reintegrated in an external program after being released from custody. At least in the prisons, you know when they're going to get out and you can plan for it. In the jail, totally different story. Number one, most jails and detention facilities have no buprenorphine treatment whatsoever. And their discharge from the facility is very unpredictable. They could bond out, they could bail out, their charges could be dropped. They could be sent out ROR because there's no capacity in the jail, for example. So the reentry from a jail or a detention facility is even more problematic than the federal prison system. As many problems as we have with that. So just keeping that in mind, that this is a priority. Medication-assisted treatment is a priority. It can be life-saving, life-changing.
Thank you. I appreciate that information. The Bureau of Prisons has something called FSA, First Step Act. And the probation officers are aware that this person is going to release, let's just say October the 12th. And then next thing you know, we get a knock at our front door at the office. Oh, I'm out. And wait, what? You're not getting out till next month. Oh yeah, FSA, First Step Act. So it's unpredictable there as well. But I totally agree with you. We now have our the doctor from the halfway house who is referring these people out to the MAT programs. We have her sending us monthly who is on this medication, because before we didn't know. Now we know. She now understands, oh yeah, I guess the POs need to find out about this. So we have her sending out to us who is on this type of medication. So at least the probation officer can get start working it and referring before he releases, he or she.
Thank you. And I see some additional comment here from Deanne in the chat. Thank you for sharing that. Any other questions or comments or thoughts on what could have been done differently in this case? Yes, Jeremiah.
I would just offer that this seems like kind of like probably like a very common example, right? Because this need to connect folks to services on the exit is like increasingly recognized. There are all the different states and counties have some degree of a program or no program or well-established program, and I'm sure there are lots of kind of best practices out there, but it's ongoing, challenge, and connections to care, connections among people is always this ongoing problem. So it's I don't know. I guess it's this endless challenge, but good for you for trying to make those connections and keep folks alive.
I have a question. I'm wondering if anybody in the audience works with any of the state prisons that where individuals come out, and if they have any kind of reentry activities going on, or if they know of any of that, maybe any of the providers, if you have any information on that.
I would just tell you, Cindy, that we are connected with the Baylor Scott and White. Those are the physicians that treat our residents here. The Baylor Scott and White program, and that program is continued once they release. Baylor Scott and White works with the client prior to and then when they release. So that connection is already made for them there. I don't know if that answered your question, but that is a connection between the state and the community resource.
Yes, thank you. Yeah.
Any other thoughts or questions about like what kind of SOPs could be put in place in these situations, and how could that be facilitated? If somebody has an experience about that.
I would like to hear a little bit more from Melissa. Is it Hubenak? She says, I love the reentry team. If she could tell us a little bit about, what she knows about that team.
Melissa?
My phone wouldn't let me unmute, and I am driving, listening to you guys. But no, so we have something similar to a reentry team. I guess they go and do reach in with the people in the courts or in the jails, and I just think it's an amazing thing. I know people that have been through that and how much it helped them, to get back into the regular swing of life when they've been. So I was locked up as well, and I didn't have the same assistance that I would have needed. I didn't even know how to acclimate myself back to normal life. And so something like that, I believe it would be a huge, huge help and a big deterrent from people going back to the lifestyles they're used to, That's all.
Thank you, Melissa, for sharing that. All right, any other thoughts or suggestions for Cynthia or anybody else who has been in a similar situation? And if you were able to use a reentry team or something similar to that.
This is Brandon. I just think in closing, what Dr. Miramonte said is so correct, that this is the most vulnerable time for people getting out of prison. Rather, getting out of prison is the most vulnerable time for overdose. And I've seen people die myself within hours of getting out. One of the obstacles, just to emphasize, is prisoners lose their Medicaid. So it's not only connecting with services on the outside, but it's also making sure that if you're connected with services, but you can't pay for them, like it's in effect not being connected. I see Cynthia nodding. So in the effort to build out the connections and do the warm handoff, somebody needs to re-enroll these formerly incarcerated people on Medicaid, or they won't be able to afford the buprenorphine and the things they need. And that's got to be first top of mind.
That definitely is huge. While they're in custody, even at the halfway house, they can't do anything because they're still technically in prison. So that's a big thing. And as you well know, I work for the federal government. So their big thing is who's going to pay for it. And so, yeah, we want to refer them out to community resources, MAP programs. We can't do anything till they're done with custody. So we can get the appointment set up if we know that they're on that medication. And that's why we're now finally on the road to doing that.
I think it's important too that, like Cynthia said, it's a federal government and sometimes they're watching their budget, but there are, just FYI, there are budgets with the federal probation offices for medication-assisted therapy. The key is that these procurement specialists that get those contracts for y'all have to be up on the information. If they're not up on the current medications, how can they go out and search for those contracts? So if they're still have, because I know there's a contract in the federal system for medication-assisted therapy, but they're obsolete, the medications are not updated. So we need individuals that are specialized in that to contract for buprenorphine, contract for Suboxone, contract for some of the medications for mental health.
Thank you so much, Cynthia. That's an excellent point. In the interest of time, I would request Dr. Miramontes to summarize the session today. Dr. Miramontes?
Sorry, I'm remote today. I'm not on my usual computer. So today we had a wonderful presentation and a view from inside the prison system that some of us have no experience in, and what struggles that our patients and clients have upon reentry and all the challenges they have. It's actually harder coming out than it is to exist in the prison sometimes as far as logistics, because now they're in the wild world with all these challenges such as transportation, medications, appointments, jobs, bills, debts. And so we had a good look at what these people are going through throughout their transition from prison or state jail into our community. We heard from our experts on the receiving end of that, the probation side, on how they have to work through those challenges. And so I think the big thing about today is for other folks on the call is to have some empathy, some understanding about what these folks are going through and trying to link them to services. And a lot of these services are life-changing, life-threatening, life-saving rather, if you can get them connected properly. And I think this was a good session to kind of highlight our corrections folks and the hard work that they do to take care of our patients once they are out of custody and now in our community. I think that's a good summary.
Thank you so much, Dr. Miramontes, and thank you all for joining us today at today's session. Once again, a big thanks to Cynthia Mendiola for the wonderful presentation and Cynthia Gonzalez for sharing and bringing this case to us. As a reminder, to earn continuing education credits, please complete a post-session survey using the link in the chat. If you would like to present a case, please email the BWUD Texas team at cstat.itasca.edu. We look forward to seeing you at our next session on Thursday, October 10th, at 11 a.m. Central. Have a wonderful rest of your day. Thank you so much.